This is Sally Schessler, the Director of Education for Allergy and Asthma Network, and welcome to our 2017 webinar series titled Advances in Allergy and Asthma. Our webinars are also brought to you by the American College of Allergy, Asthma, and Immunology. The goal of our webinar series is to share guidelines-based information and resources with you that are relevant to your life and your practice. This series helps the Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. This webinar is titled The Evolution of Food Allergy Therapy, Past, Present, and Future, and we are joined today by Dr. Matthew Greenhawt. Dr. Greenhawt is board certified in pediatrics and allergy and immunology. He currently serves as an associate professor of pediatrics at the Children's Hospital Colorado and the University of Colorado School of Medicine. He is the director of the Children's Hospital Colorado Food Challenge Unit. While at the University of Michigan, he co-founded and co-directed the Pediatric Combined Eosinophilic Esophagitis Clinic and was the research director for the University of Michigan Food Allergy Center. As a graduate of Tufts University, where he earned both his medical and Master's of Business Administration degrees, he completed a residency in pediatrics at the New York Presbyterian Morgan Stanley Children's Hospital at Columbia University Medical Center and fellowship in allergy and immunology at the University of Michigan. He also received a Master of Science in Health and Healthcare Policy at the University of Michigan Rackham School of Graduate Studies. Dr. Greenhawt's specific research interests include parental understanding of food allergy risk and shared decision-making, utilization of food allergy-related health services, adherence to practice guidelines, optimal strategies for diagnosis and treatment of food allergic disorders, prevention of food allergy, and quality of life among families with food allergic diseases. Dr. Greenhawt aims to use his research to influence food allergy-related healthcare policy and advocacy, and is very active at the state and national levels in support of food allergy-related legislation. He serves as a member of several national committees for both the American Academy of Allergy, Asthma, and Immunology and the American College of Allergy, Asthma, and Immunology, and has served as an advisor on behalf of these organizations to the Centers for Disease Control Advisory Council on immunization practices pertaining to his work with influenza vaccine. He is the current chair of the Food Allergy Committee for the American College of Allergy, Asthma, and Immunology. He's a member of the Joint Task Force on Allergy Practice Parameters and was a member of the NIAID expert panel regarding food allergy prevention and the timing of infant feeding. Additionally, he serves as a medical advisory board member to several national food allergy advocacy organizations and on multiple specialty advisory boards of companies related to products for food allergy management and treatment. He has consulted for foreign governments regarding aspects of food allergy healthcare policy. He is a peer reviewer and an editorial board member for numerous journals and serves as associate editor for the Annals of Allergy, Asthma, and Immunology. Well, now it's time to talk about food allergies, where we've been and where the therapy is heading. Dr. Greenhawt, thank you for being with us today.
Thank you. All right, so we're going to talk about some aspects of food allergy therapy today. We're in an exciting phase right now because we're on the cusp of hopefully 2 products that will be approved within the next, hopefully, year to 18 months with some luck, maybe a little bit longer, but it's on the horizon. So it's a good time to sort of review why food allergy therapies are important, where we've been, where we are now, and where we might go. Oops, where's the, so here I have, there we go. Sorry, it's not changing on my screen. I have a number of disclosures. There's my disclosure slide. The goals for today, we're going to understand the history of both OIT, EPIT, and their potential present benefits, understand alternative approaches to treating food allergy, things that have been tried in the past and might be tried in the future. But more importantly, understand the complexities of the choice to consider enrollment in a food allergy therapy. And with that, I want you to keep in mind that what we do is a very delicate balance. While we are focused on treating and curing food allergy, like with any therapy and any drug and any sort of disease, not everybody is going to be treated or be able to be treated. And for those, we have to focus also on maximizing how we can live life with food allergy. So this is a delicate balance. I think in the past, we've been too far focused on the right because the side here on the left really wasn't a reality. And now I think we just have to be careful not to tilt too far back over so that we're only sort of rowing with one oar in terms of what we need to do to help all of our patients. Food allergy, we know, is a rather devastating illness for families and for our patients. It affects about 8% of children, and that prevalence estimate is actually being redone now, and hopefully will be out in the fall to winter. For right now, we know that there's no cure or treatment, and that for certain allergies in some individuals, this is a lifelong burden that they carry. We know that we can't really reliably we can't really reliably predict reaction severity. And we know that for in some instances that accidental reactions happen, and they can happen from trace amounts in some very, very sensitive people. It's associated with poor quality of life, and that there's a high cost to society, both at the macroeconomic level, about $25 billion per year, but at the individual patient level, almost $4,200 per patient per year. And this comes with a rather excessive psychological burden that I think these families carry. And this has been defined many times in the past too. I think there's the fear of accidental reactions and persistent vigilance. There's the fear of hidden ingredients. Hopefully that has eased with the passage of good labeling laws and better disclosures and reporting. But there's always been this fear of not being able to treat a reaction appropriately. This burden that we've been living with, that there might not be a cure for the disease. There's this constant burden of avoidance and label reading, perception that you can't travel or do activities because of risk, a social stigma and lack of inclusion in interactions. Certainly there's a lot of literature about bullying, but what it boils down to is in some families, there's a lack of empowerment, just sort of as a cumulative sort of result of all of these burdens. When we think about treatment, obviously that last slide with the burdens, that's a lot of what motivates quality of life and what we think about decision making in food allergy. But when we think about decisions, what's really going on inside the head of the caregiver who's most likely driving the decision on behalf of our patients? And most food allergic patients are pediatric, so they're not directly making the decision. A parent is usually making it on their behalf. And what are these caregivers thinking about? What might be going through their heads? Some might focus on, I want to enter into therapy because there might be a perceived benefit versus preventing an accidental death. And I think that is a big one. Whether our patients say it or not, I think that's at the back of everybody's mind. Some might prefer to avoid a therapy that becomes burdensome. I don't want to come into the office every week or twice a week or 3 times a week or do something that is requiring some repetitiveness or whatnot. Some might not want to do a therapy that's very costly, or others really might not care about the cost. They want a therapy, it doesn't matter what some of the constraints might be. For some, there might be realistic or sometimes unrealistic expectations about what this therapy might deliver. And that could be a reason why they want to make a decision about it. And some feel that maybe just doing something is better than avoidance, because avoidance really, it's quite unsatisfactory. They want something better. They want their child to be better. For us as providers, we really have to sort of define the expectations and the goals. We need to be realistic about what these therapies can and can't do. We can't promise our patients the world because as of now, these therapies just are not aimed to deliver that. Realistically, we're dealing with therapies that are aimed to prevent sort of untoward events from accidental exposures, but they're not necessarily geared towards sort of promoting tolerance where you can eat these products, these allergens ad lib. So we need to make sure that when we're talking to somebody who's interested in therapy, that they understand exactly what they can and cannot get out of this. And that's really on us. So we have to learn the data about these therapies very well. We also can't be too sort of judgmental or over prescriptive. We're guides here. We give our patients options. It's up for those patients to then take those options and decide what's best for them. Now, we're supposed to facilitate this discussion and sort of help them make a shared and informed decision, but it's really not up to us to put our values into them and sort of force their hand. I mean, a lot of patients, I do think, sort of look for that. Well, what would you do, doc? What are you recommending? And that can become uncomfortable because we're not them and we don't know very much about their lives. So it's something to think about. And again, have this discussion with your patients. And we'll go over this towards the later half of this talk. But at a minimum, we really have to inform these patients what is going to work best, if we even can tell them what's going to work best. So we have to know our stuff to be able to help them. Let's talk about some of these therapies that we're dealing with now. So the first one that we've been dealing with, and we've been dealing with this for, I guess, coming close to now 12 years or so, is oral immunotherapy. What do we know about oral immunotherapy? Well, just like any type of allergen immunotherapy, this is a slow, medically supervised re-exposure to increasing doses of one's allergen. And unlike something like venom or inhalant immunotherapy, this is taken orally, hence oral immunotherapy. We know that from the studies that have been done, a lot of subjects who have gone through this experience some degree of desensitization. I think it's probably more true than not to say that most subjects have increased their threshold, but not everybody necessarily increases their threshold. But I think it's also very true to say that very few have developed this sort of concept of sustained unresponsiveness. That's what we're calling tolerance these days. It's a sustained unresponsiveness to allergen exposure. Tolerance is a floating term. It might mean something different to everybody. To me, it means that you can eat as much or as little of that allergen whenever you want, wherever you want, in any form. If you want to take a break and not eat it for a year and then come back, then you can do that. Sustained unresponsiveness, I think, has been tested at a concept of let's not eat this for a couple of weeks and see what happens. So we're pushing the envelope, but that's where we are. And I think sustained unresponsiveness is a pretty good descriptor of that. With OIT right now, we don't know how long this therapy needs to occur for them to gain an effect, or how long the effect lasts. You could make the argument that with both inhalant and venom immunotherapy, we're sort of in the same ballpark. We know it's recommended for a couple of years, but there's a lot of variation with that. With OIT, it's less certain. We're really missing a lot of long-term data on this, so we don't know. Right now, it's sort of viewed as sort of an indefinite type of experience. The effects so far have been seen fairly equally with egg, milk, and peanut. I think peanut is the most studied allergen, but milk and eggs certainly have their data. And what we see in terms of immunologic biomarkers is that there's decreased allergen sensitivity, and that goes pretty quickly over the first 18 months of therapy. We see a shift initially where allergen-specific IgE increases and then decreases, and then over time you see an increase in allergen-specific IgG4. You can also see shifts in the part of the allergen recognized, the epitope. That's been shown with peanut. There's a variable degree of effect of other immune cell shutdown. They're aiming to sort of look at the IL-10 and FOXP3 as markers of tolerance, shifting in cytokines away from IL-4, 5, and 13. Nothing consistent has been shown, but there are many targets of interest, and I will leave it at that. The typical OIT protocol is more or less a variation on this. For a number of years in the early days, this entry challenge pre-study didn't exist. We weren't challenging people, but probably since about 2010, 2011, you're not going to see any studies where entry challenge isn't thought of as sort of a necessary prerequisite. So you want to make sure that the patient is still allergic and how much they can tolerate before therapy. Then there's the rapid desensitization. So they're built up to a certain level over the first day, and that can be anywhere, it's been described anywhere up to 12 to 50 milligrams. I think in the earlier days, there were fairly high doses that were used, and that was back down. And then it's followed by a maintenance phase that can persist anywhere from several weeks to several months to even several years. And this is where you build them up to a certain level and then you hold them. And they keep taking that dose every day. Step-ups are generally done in the office about every 2 weeks under observation, but once they show that they can tolerate that in the office, they go home and they take that dose. In some studies, there's been an interim challenge, but not all, followed by a continued maintenance phase. And then generally, this has been common to all protocol, there's been a end of maintenance challenge to sort of denote, well, where are you now after therapy? In some of the trials, this is where the placebo group has been crossed over and put on active therapy. Following this end of maintenance challenge, there's generally either a continuation or discontinuation of variable duration. And this is where sort of the theory of sustained non-response is tested. Some studies have done, 2-week interruptions and some 6-week interruptions to see, can we take a break from this? Are we showing that, you've built up a level of non-response that can withstand not being exposed to the allergen? And again, these are things that have been tested in certain studies. And then, everything comes to an end in most of these studies. There's some end of study challenge where they go on to sort of an open label phase. So this is what most of the protocols have looked like. Contrast that to the Immune protocol. This is for ARC-001. This was the phase 2 for their commercial OIT product. It's got a lot of common features that I just described. There's a sort of a screening double-blind challenge followed by an updosing phase to a maintenance target where that's held, and then there's a challenge at the end. In this study, entrants were excluded if they had a cumulative challenge dose that exceeded 43 milligrams of peanut protein. So they were looking for people who were reacted to very, very small amounts of peanut. And they built them over day 1 from 0.5 milligram up to 6 milligrams in a couple of steps. And then slowly every 2 weeks, they kept more or less doubling the dose until they hit a target of 300 milligrams where they were maintained for multiple weeks. After the maintenance phase concluded, they were brought back for an exit challenge, and you can see the challenge doses here. So a total cumulative dose of 1.043 milligrams. And their endpoint of this study was the percent tolerating a challenge cumulative dose of 443 milligrams. And the second endpoint was those who tolerated the entire thing. And this is, of course, compared to placebo. And here you can see this actually worked quite well. So we're looking now at probably more of a per protocol analysis. You're looking at those who actually completed the full course of therapy and the challenge. The gray bars represents those on placebo, and hopefully this is coming up as teal on your screen. It's teal on mine. The ARC-001 completers. And if you look at the primary endpoint, that was a top dose of 300 or a cumulative dose of 443 milligrams. You can see that everybody who completed on active therapy achieved that endpoint versus only 19% of those on placebo, which is about what you would expect following the natural history of peanut. You're looking at about 1 in 4 to 1 in 5. Additionally, they were able to show that everybody who was able to achieve the primary endpoint was actually 78% were able to achieve the secondary endpoint of over a gram compared to placebo. So looking at this, among those who were able to complete it, this was highly successful. These numbers needed to treat are hovering around 1.3, which is very, very good. Now, small study numbers, but again, this is something to get excited about. This is a low-dose OIT protocol therapy. You're only going to a top maintenance dose of 300, and it's getting you, protection at about a gram. I think, that's pretty good. That's much better than we've really ever been. If you look at the pure intention to treat results, again, you can see about the same level, well, just a little under the same level of those hitting the primary endpoint. There were a couple more dropouts here in the active group. But again, you're looking relatively within the same ballpark. So this phase 2 trial worked really, really well. This is even more exciting. If you look at this, now they're looking at among those in the completer population, so this is more the per protocol, those who were able to get through the challenge, you're looking at now at, based on the dose, how severe were some of these reactions. This top row here, where you can see it goes from sort of green to lighter green to orange to red, you're looking at more and more severe reactions requiring epinephrine as you got up to higher doses. And that's what you would expect to see with a placebo. Here you're at low dose, but then again, you're starting to see more and more epinephrine use creep in here. Contrast that to the active group, where really even at the top dose, you saw very, very few reactions even sort of hit the moderate level. So not only did it work, I mean, again, and look at this, again, you're seeing massive absolute risk reductions between both groups here. Good numbers needed to treat. So this is successful therapy. And you're showing something else on another axis, that the severity of the reactions for those who were able to get through this therapy also decreased. So this is very, very favorable. This is what we want to see. We're seeing some modest level of protection, and you can argue if a gram really is clinically significant or not. I think it takes care of an accidental bite, a couple of peanuts worth, which is really all that it was aimed to do. And it takes care of the severity of the reaction resulting from that exposure. So I think mission accomplished. That's very, very promising. Now, phase 2 data, this has to be optimized. And right now, the phase 3 trial, the Palisade trial, is ongoing with a very similar design. except now that they've changed the primary endpoint. Instead of just moving up from that basically tenfold, they want to go to almost a full log-fold increase in tolerance, up to 1 gram for everybody. Enrollment is complete. The final challenges for this, the exit challenges, are being completed, and they should be analyzing the data in the last quarter of this year into the first quarter of next year. And hopefully, if the results are favorable, there'll be a publication and they'll be before the FDA waiting for this to hopefully gain approval. So I think that the future is very, very bright for this. Now, again, understand what it does and doesn't do. This is your top maintenance dose here, just 300 milligrams, and it's only geared to get you tolerance to about 1 gram. And again, they're looking at a proportional response between placebo and active. That doesn't mean that everybody gets here, but they're looking for roughly a 30 to 40% difference between those two groups. That's all that this study is powered for, to my understanding, or in that ballpark anyway. You know, and you know, the median and mean response might differ, but again, you're looking for the proportion that can get above that compared to placebo to show success. And you know, at 1 gram, I think, you know, you're taking care of an accidental bite or so, and hopefully moderating the severity that would result from that. So again, very, very promising. Even more promising is a twist on this, and this is hot off the press. This actually was released in Lancet Child and Adolescent Disease last week. Lancet now has its own pediatric journal, and this is the inaugural issue. And this is from the group at Royal Children's Hospital in Melbourne, Australia, led by Mimi Tang. And this is a continuation of their PPOIT study. So PPOIT stands for Peanut Oral Immunotherapy with Probiotic. And if you remember at the 2015 Academy meeting in Houston, Mimi presented her data that had just been published in JACI at that point in time about a rather successful trial comparing this novel PPOIT formulation versus placebo in a small group of patients. And in that study, a double-blind randomized controlled study comparing PPOIT versus placebo, with the Lactobacillus rhamnosus being the probiotic used, they showed rather good efficacy there. They were successfully able to desensitize 26 out of 29 patients and maintain a 2-week sustained unresponsiveness in 23 of these 28 patients. What we're seeing now is what's happened to these kids 4 years later. So these kids were on a peanut OIT. The OIT regimen was similar to most of the COFAR and NIAID sponsored investigations. But the exception was the addition of this probiotic, which is a highly concentrated dose equivalent to about 20 tubs of yogurt per day. So not something you can get over the counter. It's a special formulation and it's highly concentrated. And what they did was follow 48 of the original 56 participants for another 4 years after they discontinued the formal PPOIT therapy. So you had 24 in each group that were followed after the exit food challenge. There was no set protocol for the PPOIT group in terms of how often they needed to eat these peanuts. And that was actually a pretty interesting variable, not necessarily controlled, but a little bit of a natural experiment. So these individuals were able to eat or encouraged to eat as much as they wanted or as little as they wanted over time. 4 years later, they were asked to come back. The PPOIT group discontinued eating all peanut at that point for another 8 weeks. This is after 4 years of eating peanut pretty much on their own whenever they wanted to, then to stop for 2 months and then repeat a challenge. And this is where it gets really interesting. So they noted that 16 of the 24 kids in the PPOIT group versus only 1 out of 24 in the placebo group were regularly ingesting peanut ad libitum. And they found that half of these subjects were eating at least 2 grams of peanut per week. And if you look at the frequency here, just under half were only eating this 1 time a week. About a third were eating it 1 to 2 times a week, and about a fifth were eating it 3 times a week or more. So if you look at this, this is not actually that frequent of ingestion after the fact. You know, they've been able to stretch out that interval. They're not eating it every day. They're eating it weekly, but variable within that week. Some a little bit more than others, but you know, some of them only once a week. And they found that 16 out of these 20 PPOIT subjects were, again, consuming this regularly, and 20 out of the 24 reporting no reactions since stopping the therapy on this sort of uncontrolled regimen. Then they took 27 of the total participants, including both groups, and got them to agree to this second challenge. So they got 12 of the original PPOIT people and 15 of the placebo to agree to a challenge after, in the PPOIT group, a 2-month stop. And they found that 7 out of these 12 kids, after eating peanut ad lib after stopping therapy, and then for 4 years and then stopping therapy for another 2 months after those 4 years, 7 out of 12 were able to resume eating peanut and tolerated their challenge. And that results in a number needed to treat of just under 1.9. Only 1 out of 15 people in the placebo group were able to do this. Now, here's the take-home message from this. 7 out of 12, that's not a lot of patients, but that's slightly more than half of those in this study. They were eating whenever they wanted in a pattern that sort of mimics a non-allergic individual's consumption. Think about how often you eat some of your favorite foods. It might be very often, it might be infrequent or whatnot. I live in Denver. I don't get seafood all that often. I can take a 3 or 4 month pause between eating it, but I don't react, right? And that's what this pattern shows, that they could basically interrupt this on a schedule that somebody who's not allergic might do and not react. And I think that that's the goal. This is showing some real world efficacy here. Now, this study was not perfect. It was far from perfect. And they are very, very upfront about this. They didn't challenge people for the 2015 study. The study started in 2009, and it was before that time when they really did entry challenges. That changed during the course of that, and that's a criticism that they've had to deal with. The study numbers were not that high to begin with, and they did experience some degree of dropout. But again, look at sort of the bigger picture. They're replicating this in a multi-centered study across Australia. But again, if they can scale this up and show that this effect works again, this might completely change the game. And again, yes, they only looked at PPOIT versus placebo. This current study that they're replicating, they're looking at PPOIT versus just regular OIT. The investigators felt that there wasn't much sort of immunologic plausibility to just put somebody on probiotic alone and expect to see an effect. So they didn't do that design. So this is standard OIT versus PPOIT. And they're looking to see, can they do this again? But again, if they can, this might change the game. I mean, this pattern is, I think, what most parents would want. They want their kid to be able to, if they're going to eat a lot, and actually, if you ask a lot of parents undergoing OIT, they just want accidental exposure sort of coverage. But for those who are seeking more, a lot of them don't want to be tied to having to eat this regularly. They want to do what anybody else would do. Eat it whenever they want. And this is the only study so far in OIT that has showed this. So again, not ready for prime time in any way, shape, or form. And hopefully you're not getting a lot of phone calls about sort of the readiness of this. It's not. It's being repeated. It's not even available in the US. You couldn't replicate this here if you wanted to because it's a proprietary formulation. But again, they're redoing this study to see if they can scale up the effect numbers. And this really might change the face of what we do with oral immunotherapy. So again, I think the future is very, very bright. Again, temper the conclusion, but I think look to the future where this really might be something that we can offer our patients. Looking at some of the other published peanut OIT trials, again, you can see the original comment about these kids sort of getting up to a decent level here, having some degree of desensitization, but really sort of not a lot that reached sustained unresponsiveness. That's why I think that this last study here with the PPOIT is so different, because I think it's pushing through a ceiling that was reached where this wasn't going very far, and we were sort of in this indefinite holding pattern. And now we've shown some proof of concept that maybe you can, get some good effect at 4 to 5 years later. So I think that that's what you might see some change in design of some of these studies coming about. Milk and egg, there have been less of these studies. Again, we're in a similar ballpark. We're getting some degree of desensitization, but really nobody with sustained unresponsiveness. With milk, again, this study here from Johns Hopkins, the caution here, and there was a letter to the editor written in Jackie about this study, is that a lot of these kids, while they got up to being able to tolerate here, 7 grams of milk, which is almost a full cup, a lot of them reverted and stopped drinking it and got sick after a while, which is very different than what the Australian peanut study just showed. So milk might be a little bit of a different animal than peanut. The most recent one was showing the effect of using omalizumab to help with some of the buildup reactions, showing some sustained unresponsiveness after 8 weeks here. So again, we're looking at milk and egg sort of lagging behind peanut, but these studies are ongoing. The present state of knowledge, I think peanut, again, is sort of the pace leader here. There's been randomized controlled evidence. There have been some study in non-severe patients that's a little bit less of a finding with milk and egg. This has been looked at in infants in peanut. Again, none of these kids sort of make it through these protocols with major symptom free. A lot of them have major symptoms along the way. Almost all of them are achieving desensitization. Some of them are achieving some degree of sustained unresponsiveness. The mechanism of how this is happening, a little bit unclear. There are definitely cases of EOE that are occurring. There's some concern about recurrence of allergen even on protocol. Some of these have been twisted to some degree. We've looked at sort of the addition of anti-IgE, PPOIT. But right now, the only one that is in phase 3 trial is peanut, and that, you know, ideally, if the data follows along, should be approved. But we'll, you know, we have to see. I want to put the cart before the horse with that trial. Some of these other ones are sort of in earlier stage development, but they are in the pipeline. The questions we need to ask about, you know, oral immunotherapy, the European data differs. Is it better? These studies tend to be more aggressive. It's been studied longer, and you're seeing slightly different outcomes over there. I think we need to sort of rectify the differences in approach. SLIT was something that was tried for a while. It appears safer but less effective than OIT, and has largely been abandoned in terms of investigator-initiated studies. Long-term follow-up exists to some degree, but again, we need more studies that test sustained non-response and looking at 5 to 10-year outcomes if we can get some of those available. Side effects, this is really the major issue with OIT. Some of these reactions during buildup and maintenance are worse than one's baseline reaction, and they often prompt discontinuation. And that's why, you know, we've seen the move to adding things like omalizumab as pre-therapy to help decrease that, to get these kids up to a point where they can then be maintained. Obviously, development of eosinophilic esophagitis is quite concerning, and we don't have good predictors for that. For me, as an outcomes research guy, I worry that few of these studies are truly addressing any patient-oriented outcome like quality of life or preference. There are a couple out there, but by and large, they didn't. They were sort of more academic exercises to show, can we get somebody to this level? But that needs to change because these need to benefit our patients, and they need to have a good reason for doing it, and it needs to be geared towards their goals and expectations. We're seeing sort of a potpourri of methods. There's the industry trials, which are low-dose approaches. The COFAR trials were more high-dose approaches that have been abandoned. There's the practice-based argument. There are people doing OIT, you know, off-label in a number of different ways with, honestly, from what I have read and discussed with some of these people, very, very good success records. You know, how does that differ from these other two variations? Is it, you know, it's not fair to say that, you know, they're doing something different or inferior or superior. I mean, I think we don't know a lot about what's going on in practice, and we need that data to be published so we can compare it. They may be onto something that, you know, these other two approaches don't have, or vice versa. Who knows? There are some studies of multiple food OIT at the same time and studies combining omalizumab pre-therapy. The newer trials, by and large, have focused on this lower maintenance target, which is a different strategy and is going to give you a different outcome, and you need to be aware of that. My main question here is, will this new PPOIT data totally change the landscape, and will we see a return to higher targets because, you know, maybe there's something to doing it this way that they did in Australia? The major hurdles that we need to overcome, we need a consistent vehicle. We need to sort of do something about high dropout rates and the percent developing symptoms. We need clarity on mechanism and outcomes. That may or may not be realistic. You know, there's still some doubt as to how allergen immunotherapy works for inhalants and venom. And, you know, I mean, again, we want to know how it works, but if it works, we'll take that right now because that's better than where we were yesterday. In terms of predicting symptoms from OIT, this has been a little bit elusive. You can see candidates who look identical on paper, but they have different responses, and we just don't have an answer for why. The group at UNC was able to address this, looking at their at the COFAR experience with OIT, and they looked at the incident rate ratios of certain events in a complex regression model. And what they found was two significant factors. They found that allergic rhinitis and larger peanut skin test wheal sizes seem to be associated with a much higher predicted adverse event response rate. But other things, and this is where it's a little bit surprising, asthma and atopic dermatitis, things that we worry about as risk factors for allergic reactions, these did not least not for only for maintenance reactions here with asthma, these were by and large not significant factors. And again, really, the only consistent thing here was allergic rhinitis. Even the peanut skin test after they got into maintenance really wasn't a predictor, although it trended pretty close. So that's something to consider. Now, this is only their peanut data, and these are probably less than 100 to 150 patients, so it's not the most robust sample, but it's something. And again, it's more than we've known before. Looking at frequency of adverse events using epinephrine, again, you can see most are treated with antihistamines. Those, this is the distribution of events. What worries me a little bit here was some of these things, and we tend to think of respiratory reactions as pathognomonic for anaphylaxis. And here you can see that not all of them were necessarily treated with epinephrine. And there's some severity gradation here. Again, I'm looking at wheezing and cough. Not there, we can see subjective coughs and just throat irritation or something like that. But again, by and large, what they're telling us here is that most of these adverse events are not requiring epinephrine, so maybe that's somewhat reassuring. But I think we need more models like this. It'd be helpful to understand who's more likely to develop some adverse events. This will certainly help us assess safety. Overall, what we know in terms of immunologic changes from peanut OIT, common things. We know that the skin and blood tests tend to decrease, and the IgG4 will increase over time. There's been some evidence of decreased basophil activation, a shift from Th2 to Th1 in terms of some cytokines, changes in epitope diversity versus controls, but inconsistent demonstration of major biomarkers like emergence of IL-10 and FOXP3 T regulatory populations. Overall, I think more mechanistic studies are needed, but very likely we're going to have therapies approved well before we truly understand what they're doing. And again, that's a trade-off that we'll have to make to help people that we might not quite understand what it might do to them. Let's shift gears and talk about epicutaneous immunotherapy. Where do we stand with this? Well, a lot less has been published on this because this is a proprietary technology. This is controlled entirely by DBV with their ViaSkin platform. We're looking at Miles, which is the milk platform, and PPOIT, which is the peanut platform, which are in phase 2 and 3 trials, respectively. Early data has noted that the epicutaneous approach, which is akin to paraphrase or to show an example, this is essentially like a Nicoderm patch that you put on your skin, except it's not secreting nicotine, it's secreting allergen, and it absorbs through the skin. It gets taken up by Langerhans cells, and it goes through antigen presentation that way. Early data has shown that 70% of those in the early phase studies had a 10-fold dose increase in their threshold without serious adverse events. In the earlier milk studies, they've noted that most adverse events are almost entirely cutaneous and nothing beyond that. And that's in contrast to this slide here, where you're looking at a range of things that are a little bit more than just sort of skin only. There's been some production of T regulatory cell populations and no association with eosinophilic esophagitis. So it appears to work differently than OIT, and it induces maybe slightly different problems. You're trading maybe less internal symptoms for more external symptoms on the skin. Again, you're putting sort of a glorified Band-Aid on the skin, more or less, and that can come with some irritation, which again is a trade-off that a patient will have to accept for therapeutic efficacy. Right now, the PPOIT, the phase 3 peanut trial, is at the end of year 1. That data will be analyzed in this quarter. We don't really know any efficacy yet. The dose that they've chosen to study is a 250 microgram patch. What we do know is some of the earlier studies, and we'll look at 2 aspects of the phase 2 data. This one has been published in JACI last year. This is a 1-year safety study looking at 100 micrograms versus 250 micrograms versus a placebo patch, looking at individuals with a certain threshold on entry challenge, with an endpoint to try to get above 5 grams of peanut or a 10-fold increase, depending on what your challenge threshold was at entry. And they found that this worked pretty well. 45 and 48% of the 100 and 250 microgram patches met primary endpoint versus only 12% of placebo. And again, these are numbers needed to treat that are right around 3. That's pretty good. They found median change of 43 micrograms versus 130 micrograms with the higher dose patch. Now, again, median change, that's not looking at the actual proportion of those who responded. And what they've learned is that those with lower thresholds tend to have lower dose increases. But again, you know, the endpoints are set. They were set by the FDA, and you look for a 10-fold increase, and that scales up as you're able to tolerate more at entry. Interestingly, they found that the outcomes were better in the younger age tier, those under 11 years, and that's why you see the current PPOIT trial is focusing on those age 4 to 11. This had great safety. There was only 1 grade 4 reaction, and most were these local patch site reactions. Now, in terms of skin test decreases, they found that this was really only relative in the highest dose patch here. No absolute changes in logarithmic IgE levels, but they both tended to see this shift in IgG4 to IgE, and of course, this 10-fold increase was met. So this worked well, and they were able to move to VIPES, which was their phase 2 data. This is available on the DBV website. This has not been published yet, though. This is pretty cool data. This should encourage you that this little patch can do. And now they're looking at a 3-fold dose response: 50, 100, and 250 micrograms versus placebo. This is a much larger study over the US, Canada, France, Poland, and the Netherlands. So they had a 1-year dose-finding study followed by a 2-year open-label study. And the endpoint here was, again, either very similar to what Amion's was, a gram of dose tolerance, or a 10-fold increase of the initial challenge dose.
Dr. Greenhawt, we have about 10 more minutes to go. Just want to help you pace yourself.
Yep. So what we saw in this study was pretty good response. If you look at these doses, all of them showed significant increase over placebo. You know, with sort of the greatest increase relatively in the 50 microgram patch, but the 250 microgram patch was not far behind it. But more importantly, the median was much, much higher in the 250 microgram patch. And here you're seeing an equivalent tolerated dose of about 4 to 5 peanuts, and that was very statistically significant versus baseline. And what they found was that this was well complied with without any SAEs or FEUs related to the patch over the full 36 months of the trial. Really only 2 withdrawals, which is very different than OIT trials. Showed efficacy at all 3 doses, but again, the highest cumulative reactive dose increase was seen at the 250 microgram patch, which is why this progressed to the phase 3 at this dose. More interesting, again, look at what happened in the open label trial over time. You're seeing an increase in their response rate proportionally. The longer you wore the patch, the better this response rate got. So here's their baseline at the end of year 1. Here's their baseline went from 57% to 80% over that first year of the open label thing, and then up to 83% by the end of year 2 of the open label. And if you look here on the other graph, you can see that this median dose and the peak dose massively increased over baseline. So again, the longer you wear this patch, the more it works. So for those of you who are anxiously awaiting this data to come out and haven't heard a lot about it, I think this is also very favorable. If you look at, you've got 2 products with very, very, very favorable phase 2 data that suggests that if all goes well, the phase 3 should work for both. And we'll have 2 options for patients. And that's great because honestly, we need something. We haven't had anything. And it'll be very important to have options because one therapy might be better for one patient and the other therapy for your next one. And that's important. But let's look at some of these other approaches. Now, I think most people have heard about the ill-fated subcutaneous aqueous peanut immunotherapy trial that was done down the street from me here in Denver in the early 1990s. This was, to make sure that everybody knows this story, this was actually working, and the threshold was increasing in these patients, and the rates of adverse events were not dissimilar to some of the early OIT trials. But what happened is the placebo patient was given an active dose and had a fatal code, and that was very unfortunate, and the study was shut down. But it wasn't due to lack of efficacy. It was a dosing error. And again, you know, this did show some success. It's unclear if this would have, you know, sort of had the strength to make the full run, but again, in early stage, it was favorable. The other story that some of us know about are the story of these 2 anti-IgE monoclonal antibodies, the TNX-901 product and omalizumab, and both have shown success. The initial product to show success was the TNX-901 product, which showed which showed an increase of threshold from 1/2 to 9 peanuts in individuals given a 450 milligram dose. This drug was not commercially developed. Omalizumab seemed to have won that race. And then there was a phase 2 trial that was held in 2004. It was unfortunately halted due to safety concerns, not due to the product, but due to significant reactions in the pre-entry challenge. But in that data, it was actually showing a nice trend towards tolerance. So we had two horses in the race a while ago, both sort of stopped for their various reasons. But again, this is where the gap has been. We really haven't had any promising therapies, which is why I'm so excited about these two products. The question is, will either of these two strategies here be resurrected? Probably unlikely. But let's look inside the omalizumab trial data. So they gotten through their first 14 of planned 150 subjects. And they were trying to show an increase in threshold at 24 weeks of therapy. And again, 14 completed therapy and showed some response. But again, this was stopped prematurely. It wasn't due to the drug being, sort of non-efficacious, but, at that time we were doing challenges with product put in gel capsules, which unfortunately, as we found out, have a very odd digestion time in some patients. And one of the capsules didn't digest and another one got swallowed on a normal dose interval, and all of a sudden the patient had a massive dose and had a very, very bad reaction. And it was very, very frightening. They didn't die, but they got pretty sick. And that's why I think you see now very rigorous control over the challenge phase. If you're involved in the AIMMUNE or the DBV trial, they have very, very specific ways of doing their challenges. And that's for this reason, this historical lesson here about not using gel caps. Right now, omalizumab is really only being seen as an adjunctive therapy with peanut and milk, and we'll see where that goes. The other solution on the horizon here is prevention. And I would argue that if you can prevent the development of allergy, then that's the most effective therapy. You're preventing anything from occurring. Hopefully, if you've been alive in the last 2 years, you're well versed about the LEAP data and what that shows in the new NIAID guidelines. The data appear pretty promising, but again, we have to be able to implement that, and that hasn't been studied. I'm very quickly going to show you some of the evidence. Again, the LEAP trial showed that there was a massive and 80-something relative risk reduction between those who consumed peanut early versus those who avoided. And this is the basis of our new guidelines that came out in January that I helped co-author. This was a very, very successful study. Again, studied in high-risk infants with moderate to severe eczema, but there's no reason to suggest that it wouldn't work in those with lesser severe eczema or in anybody, and I refer you to the guidelines. The EAT study was a standard risk looking at those who were exclusively breastfed, being introduced multiple allergenic foods either at 3 months of life or after 6 months of life. And while this really didn't show any significant differences in the main intention to treat group, in the per protocol analysis, again, it showed that among those who actually complied with the therapy, that there was reduction in peanut and egg allergy. So that's pretty good evidence that this would work in a non-at-risk group too. And probably better evidence that introducing at 3 versus 6 months of life probably doesn't make a difference either in terms of rates of development of allergies. So more sort of evidence pointing towards early introduction. And now we have a potpourri of acronyms here for the various egg studies. 3 trials done in Australia, 1 trial done in Germany, and 1 done in Japan. These have showed some mixed outcomes. I think the Australian trials, the STAR trial actually was halted earlier due to, again, sort of entry challenges in kids reacting that had severe eczema. But there was a trend towards some risk reduction, not significant trend, but a trend towards risk reduction in the early introduction group. The STEP trial, which was a little bit of an evolution of this, also showed a non-significant trend towards risk reduction. And the BEAT trial showed a similar non-significant trend towards risk reduction. The trial in Germany showed a little bit of a different outcome. This is Kirsten Bayer's group, and they found that actually there was some potential risk from early egg introduction. Now, there are some subtle differences in these protocols, but again, with replication, you sometimes get a different outcome. And that, those of you who know me and have heard me speak on this before, this has been my main criticism here, is that we based our policy on just this one study, whereas with egg, we've been replicating this like crazy, and sometimes you get different results. So you had 3 that kind of worked but weren't significant. You got 1 here that didn't work and was significant. And then you have the Pettit trial that just came out around Christmas in, I think it was Lancet. And this is one that was stopped early because it worked exceptionally well and it triggered early stopping criteria. Now, this is a little bit of a different twist on the protocol. These are all kids with, they're very similar to the lead population. They are all high-risk kids with atopic dermatitis. Instead of starting them on egg at 4 months, they actually started them on eczema treatment for the first 2 months and then randomized them to early versus delayed egg introduction. And that early introduction was stepped up. It started at 50 milligrams of heated egg. It was poached egg, which is boiled for about 15 minutes. So it went from 50 milligrams then to 250 milligrams. And then they were challenged at 12 months. But this worked exceptionally well. This was highly, highly significant. And again, it triggered an early stopping because it was felt to be unethical to continue the trial. So, with this, we've seen some mixed success. I think a better way to look at this is from Bob Boyle's group at Imperial College in the UK. And this is their meta-analysis of prevention trials that was published in, about a year ago. And again, it's showing sort of the red dot here, protective evidence when you take all of the egg studies pulled together, and protective evidence for the peanut studies. So prevention can work. I'm going to move along a little bit here. The addendum guidelines, again, hopefully you guys are familiar with this. The point is that everybody should be getting it early. Some of these kids with these risk factors, maybe a little bit earlier than others, but the point is to do this. Those with the severe eczema and egg allergy or both, again, there are different criteria. For us as allergists here, this is really where we need to do the bulk of the work. A lot of these kids are sort of referred for testing. What I would encourage you is to not be afraid of these skin tests in this size. Again, if you do nothing, they're going to be allergic. That I'm pretty confident in. If you challenge them, the only thing that you'll convince yourself of is that maybe they'll pass. So again, I think you're in a controlled setting. You can control the reaction. You need to give them the chance to fail. If they don't get the chance to have a challenge, their outcome is going to progress towards allergy. So again, the only thing you can prevent by challenging them is development of allergy because maybe they'll be tolerant. Here's the cutoff that's recommended. Again, these are relative cutoffs. Work within your comfort level. With this, I do want to look at a couple of things with shared decision making. Remember, you're in a partnership with your patient. You need to understand what your patients want with respect to therapy. You need to talk to them. What are their goals? What do they want to get out of this? What are their expectations and concerns? Identify the relevant choices, go over the research with them, help them answer their questions, show them the evidence. But then again, at that point, that's where you need to step back. You put them, in front of a number of different options and let them choose. But again, our job is to really understand what those options are and be informed about that to help them make an informed decision. The things that they have to think about, well, do they have to do anything? Remember, this is not like sort of, most other illnesses. Say a patient with the severe cancer, they need to choose to do something. With food allergy, you don't really need to choose to do something. You can choose to avoid. And that's, again, they have to understand, is the process of these therapies worse than living with the disease? Understand their goals. Ask them what they're willing to trade off and what the value of that therapy is going to be compared to just life with avoidance. You need to understand their beliefs, their healthcare beliefs. That will help a lot. You need to figure out what's going to be the best therapy for this patient, and that's the name of the game. Help them decide. Maybe it's option A, maybe it's option B, and maybe it's option nothing. And again, we have to be okay with some patients not choosing therapy. It may not be for them. Really, our goal here is to develop guidelines that really help make this decision process easy for both you and your patients. Point in caution, again, you have to understand food allergy has large direct costs, but again, costs of primary prevention are low. So some of these kids will be taken off the table if we can buy into primary prevention. we need to know what's going to be the most cost-effective strategy, if any. If these therapies cost too much and are falling short on the outcomes that they deliver, then these aren't going to be good choices. They're going to be, only those who have the time, money, and patience to sort of deal with sort of low threshold outcomes. And that's, hopefully that's not the case. But again, you need to understand what these therapies do and what they don't do so that you can put the best patient on the best therapy. In conclusion, we do have multiple potential approaches. None have really been proven to date yet, but there's some exciting preliminary evidence. Just remember, entering into therapy is a complex decision, and we have to help them make this decision. It's highly personal. There are preferences and trade-offs that you have to help fish out from some of your patients. And again, this is the goal here is learning how to make a shared decision and not sort of being too paternalistic with it. Cost effectiveness, all that data will come. For now, again, there's this great promise, but start talking to your patients about what their options are. And when you ask them, they'll tell you what they're comfortable with. And I think it'll become easy. And with that, I will leave you with yet another beautiful sunny day here in Denver. This is a picture from October. We don't have any snow on the mountains right now, but it does look like this today. This is the view from one of our rooms where we do our food challenges. So I encourage you to come on out to Denver and spend some time with us. And I thank you.
Thank you so much, Dr. Greenhawt. Do you have another 10 minutes to spend with us to do a couple questions?
Sure.
Okay.
We started a little late, so yeah, no problem.
No problem. I just wanted to make sure because I know you're in clinic today, so I always want to make sure we're not holding you up. First of all, I would love to come to Denver and see those mountains, but here we've got a couple of questions from our listeners. We're getting many parents with high anxiety regarding students with a life-threatening allergy, but they've never really been received information via a skin test. The concern is that children are coming to school with increased anxiety, and their peers or best friends are bullying them, and if they can't have a peanut butter sandwich, and they want to know how are concerns being addressed in the provider's office and approached with parents and families.
I guess the best answer is with a high degree of variability, and that's not good. And I think that we're not necessarily consistent in our message. Depending on who your allergist is, you're hearing different things. So I go back to the first part of that question. I don't understand why these kids are not getting skin tested. This is a normal, you have to do this. You have to reassess it. Some of these kids, it's going to change. If you don't run the test, you have no idea if they've changed from point A to point B. And, the natural history data could shift, and you could be an active participant in that if you want to. So, the other thing is just make sure that we have good indications for testing. Make sure there's a good, clear history. Test to a very narrow panel. If they only ate peanut, don't test the things that they didn't eat. Stop running the panel test. That will help sort of clear up some of the noise that some of these kids sort of come to school with. Now, in terms of the bullying, that's its own webinar.
I agree.
That's very tough. I think, kids can be very mean, and they can find unfair reasons to be mean, and food allergy is one of them. Now, and there have been some cases of bullying. There's this case in the UK now where this kid got a piece of cheese thrown at him and ended up having a fatal reaction. It's not clear what happened there, but it was clear that there was bullying involved. This is very, very frightening. It's a problem on both sides here that the kids need to understand this is not a laughing matter. And again, it's how do you control all these other kids? They're not your patients. Your patient is the one being picked on, and you're not there. So, you got to talk with them. You got to, set up things with the school. Zero tolerance policies are good, but they're hard to enforce. And I think no school wants their students to be bullied for any reason, let alone food allergy. I just think, it's a problem that doesn't have good solutions. And, there's not a lot of research into it either. We don't really understand why this happens other than kids just find what they think is somebody's weakness and go after it. I remember getting picked on as a kid myself. It never made any rhyme or reason, but, it happens. And, this becomes sort of another lever, for somebody who's going to bully one of these kids is that they can, play around with their food allergy, which is terrible. I really don't have an answer for that. I'm hoping that, maybe some of these kids who are bullied, maybe some of these therapies, maybe this is a motivation for why somebody wants to go on therapy. I mean, I hope it's, you know, that they feel that they have to go on therapy because their kid is getting bullied and they're afraid of an adverse outcome, but that's probably going to fit the bill for some of these kids.
Well, and the network has a new school guide out. You can find it on our website under Outreach and Special Publications. And we do have a couple articles about bullying, so that might be a help to you as well. The next question is, what are the chances of children having an airborne peanut allergy?
Yeah.
Did you just drop something?
I dropped my phone. Looking at the time. I was going to say, oh, I'm short on time. Yeah. Okay. So
should we? Do you want to answer that one, or do you want to move on?
I'm happy to answer this one. There have been no studies conducted to date that have shown that peanut aerosolizes and that inhalational reactions can be provoked. That is not to say that people don't believe it happens and that people don't report it happens. That is to say that when they've tried to study, can you actually make peanut go up in the air and be detectable? They have failed to do that. That to me would preclude that one can inhale it. If you can't detect it in sort of studies deliberately being done to trigger the release, then either those studies were poor, flawed, or maybe it just doesn't happen. It's one of those three things. I've looked at the rigor of that. I've talked about this, about reactions on airplanes and stuff like that. I tend to think that there is probably a very low likelihood of an airborne reaction. Again, if you're talking about from peanut butter, I would say that's not going to happen because peanut butter, the smell doesn't contain any protein. It's a volatile organic compound. Now, people might have other reactions from the smell. There could be anxiety reactions. There could be vocal cord dysfunction. There could be lots of things that make it look like, you know, stress-induced hives, something like that, that can look, you know, pretty close to the mark there. But they've done studies and they've not shown anything happens from inhaling peanut butter. Peanut can be abated in the environment. So again, I think we're probably focusing on the wrong thing. And you know, again, that's where the evidence is. That's not to say that it couldn't change in the future. But that's to say that's where it is right now.
Thank you. That was a lovely answer and brave nonetheless. Okay, someone's asking if the Tang study was funded by a pharmaceutical company or a university.
It was sponsored by, I want to say, a couple of different sources. I believe they got the probiotic from a pharmaceutical company. So I think the company provided some funding for it, but I don't provided the probiotic, but I don't think they directly funded the study. I would direct you to the disclosures in the Lancet paper for that. But I'm pretty sure she had multiple funding sources for that.
Okay. What age is the cutoff for OIT for peanut allergy? Is a child over 12, is that appropriate to use for that?
I mean, it's being studied. The nice thing about Ammune's product line is that they're studying the Palisade study right now covered individuals age 4 to 55. They have another one planned that will cover kids age 1 to 4. So it looks like OIT could be something potentially used in all ages. So yeah, you know, I don't know enough about sort of the age stratified responses. I don't think that data is available. But certainly, you know, I'm not aware of any reason why it couldn't be used in a teenager. I mean, again, over time, we might find that these things work far better in younger than older kids or vice versa. But as of now, you know, and again, that would be by strict percentages. But yeah, I wouldn't, if you thought OIT was appropriate for a 12-year-old, I wouldn't necessarily dissuade you from doing it. Was there a follow-up? Whoever's asking that,
there wasn't a follow-up. And that's always the issue with questions, is that you can't always see the intricacy of the question. So our next question is something that's been in the news lately. In fact, Asthma and Allergy and Asthma Network, we just put out our monthly e-newsletter, and we addressed this article. But they're wondering if there's any information reported recently in the fatality of the office baked milk challenge.
Nothing more than has been available for a couple of weeks now.
Okay.
And I probably wouldn't count on much more getting out. I will say this. I have a little bit more knowledge about this situation than I think the average person, because I've been in contact with some people. I will say offhand, I think this is like a clear day lightning strike. This was just a terrible outcome. And, you know, we can search and try to find a mistake. And I don't think one was made. I think, unfortunately, we had a 45-year run with no fatality. That's pretty much unmatched in any procedure in medicine, especially allergen immunotherapy. And I think, you know, it goes to show you that there's a risk involved in everything. And an exceptionally well-trained allergist who is held in very, very high regard by the allergy community, with a patient who was appropriately screened, and from description appears to be appropriately treated from what I understand, and just the kid did not respond. And that's the unfortunate thing. You know, sometimes things happen. I don't have another explanation for it. I wasn't privy to all the, I didn't look at the records or anything like that, but this is the information that has gotten around the rumor mill, that this looks like everything was done right and the poor unfortunate incident happened. And again, my advice is just like what the Academy and the college and the Canadian Society letter said: go over the risks and benefits, make sure that you're prepared, you have a setup, you have a clear protocol, you know where your emergency medications are, that they're drawn out, that you know what your stopping criteria are, that you screen for asthma. I mean, cross your T's and dot your I's and get informed consent. And again, if you're in doubt, stop the reaction, treat with epinephrine. These are basic common things. I don't think that this is any more dangerous than administering allergen immunotherapy to somebody. It's pretty much the same thing. That's a live challenge every time that they get something. And again, I think most offices are set up to handle that. There's no reason why you can't be set up to handle a food challenge either, in my opinion. Or at least I'd like you to be inspired and empowered to think the same.
Thank you so much. We're going to do 2 more questions. The first one is, can a child have an allergic reaction to the fish aroma with a fish or shellfish allergy? The example is a school cafeteria cooking fish and the child having symptoms.
There have been case reports, and that's about all I can say on that. I think in theory it's felt that there could be vapors, but you know, I don't know at what point in the cooking process that happens with, or what type of cooking process. So I unfortunately have to defer on answering that one. I think, you know, there is some concern theoretically, but I don't know the validity of that. And I certainly, in my experience, have never tested that. But I think, you know, there have been case reports where that has been alleged.
Well, our last question is another one of those that could be a whole nother webinar, and maybe we should plan one for this, is what are your thoughts on schools going nut-free?
Yeah. Didn't anybody want to ask on treatment?
Well, yeah, so many people listen and they have so many issues, you know, that they're dealing with.
Yeah. No, I personally don't think it's necessary. That's my personal opinion based on my research and understanding of the literature. I think it's impossible to enforce. I think that there's no data that supports that that's associated with better outcomes. I think it provides a false sense of security. In certain age ranges, keeping peanut out of little kids' hands who are going to touch everything, that may make more sense. But at a certain level, by banning the allergen in the environment, we are not helping kids develop adaptive skills to learn how to negotiate their environment. There is a defined need for them to understand that this world has lots of things in it that we might need to avoid, whatever that is, and that it's not realistic to expect that the environment is going to be that tightly controlled. If you go back to the data, and this goes back to the question on airborne reactions, your risk of developing a reaction from peanut is from direct ingestion or contact with mucous membranes, which is ingestion. Peanut can be abated from surfaces, hands can be washed. You know, I would rather, I'm not saying I like this any better, but I'd rather the person with the allergy or the person eating the allergic food, I'd rather some separation be done within the school, if that is felt to provide a better sense of safety, than see it completely eliminated. I will say this from my work with the CSMOT Children's National Poll. When we looked at a random sample of both allergic and non-allergic parents, there's very little support for these widespread bans. And there seems to be more support amongst those who don't have kids with food allergy than among those with kids with food allergy. And that would be my take-home message. I think there are some who advocate for it very, very strongly. I also think that they're a vocal minority, and I think that the majority of and again, it's a very loaded question. Sally, you should have answered this. You're much more versed in this than I am.
My answer would
all over myself here, but I honestly think you have no data that show that this works, and that's the dangerous thing. Is you're putting something in place because you think it'll work rather than you've shown that it'll work.
Well, and Matt, my opinion is, and I'm stressing the word opinion, is right along with yours, is that I think you do get a false sense of security if you've banned peanuts, because things can get into a building. There's too many people, there's too many issues, there's too many ingredients in art supplies or food or anything. But and I think people's vigilance goes down if they think that something is peanut free. And I think when your vigilance is up, we can really prevent those accidental exposures.
That's true. I would say this too, is that why peanut over any other allergen too? Milk is just as dangerous to somebody with a milk allergy as is peanut to somebody with a peanut allergy. And if you ban peanut but you allow milk, then there's a sense of equity. And then what do? You ban all food in school? The school system was never set up to deal with this problem. This wasn't when they're like, hey, let's serve lunch at school. Oh, that's a great idea. The kids will probably be hungry. They just never thought that, well, we might have up to 10% who have a food allergy and this could be a problem. And it just was, when they started serving food at school, this wasn't an issue. And again, this is bigger than sort of any answer that I'm going to provide here. These are all my opinions, by the way. I declare, I'll make sure that you guys are aware of that. There's some evidence in there, but again, it's a very complex issue. And I would say get all the stakeholders together, talk it out amongst yourselves. See, maybe if you do that, you might find that opinions are more aligned than you would imagine, but at least you get the range of opinions and you'd be able to negotiate something there. And I think that that's probably the most logical solution.
Well, your opinion is a very educated opinion, but also I think that there's just a real call for, and I spent years as a school nurse, there's a real call for helping children to learn how to live in the real world. And the school environment can be a fairly controlled environment to learn that in. Well, thank you so much today, Dr. Greenhawt, and I'd like to thank our listeners for listening today. The Allergy and Asthma Network will be having our September webinar on September 20th at 3:30 p.m. Eastern Time, when Dr. William Berger will present on asthma vitals. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. There you can also view all of our archived webinars. So please visit our website for quality guidelines-based resources on allergy and asthma, and also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. So thank you for joining us. We look forward to having you register to be with us the next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We wish you a great and a healthy day as we work to breathe better together.